stroke syndromes of posterior circulations. Done by Dana Marafi. Posterior circulation. Posterior circulation. Arteries and structures they supply. PCA, temporal and occipital lobes, parts of thalamus and midbrain. SCA, midbrain and superior cerebellum. ACA, pons and cerebellum. PICA, medulla and cerebellum. Basilar, pons, other branches. Vertebral. Anterior spinal, upper 2/3 of and. Surface of spinal cord. Specific supply occipital lobe, PCA. Temporal lobe, MCA, superlateral, and P.C.A. Rest. Midbrain, PCA, and surface, SCA, post surface. Pons, basilar, mainly, ACA. Medulla, and spinal, vertebral and pica. Small region by, post-spinal. Thalamus, branches from PCA. Cerebellum, SCA, ACA and pica. Posterior circulation strokes form 20% of all ischemic strokes. Mortality is around 4% except for basilar artery occlusion where it can be up to 90%. However, outcome is not very good. Usually caused by lateral involvement. Severe headache, vomiting and nausea are more common in posterior circulation strokes. Vertigo, nystagmus, hemiplegia or quadriplegia, ocular eye movements, ataxia and change in level of consciousness are also seen. When to expect post-circulation stroke in a patient. 1. Different symptoms and different functions or STR. Affected in a way that cannot be explained by a cortical region, many tracts or cranial nerves involved. 2. When patient is presented with vomiting, nystagmus, nausea, ocular movement disorders or vertigo along with the other symptoms. Arteries and syndromes. From superior to inferior, PCA occlusion. Basilar artery occlusion, locked-in syndrome. Branches. ACA occlusion. PICA occlusion, Wallenberg's syndrome. Vertebral occlusion. Anterior spinal artery occlusion. These syndrome can be produced by occlusion of not just mentioned artery but the other arteries as long as the same ST are involved. However, they are commonly seen in case of occlusion of the mentioned artery. PCA occlusion. Lateral surface. Medial surface. PCA occlusion contralateral hemianopia, with macular sparing. Memory deficit, damage in hippocampal formation. Disconnection syndrome. Bilateral PCA occlusion equals blindness plus inability to form new memories. Left homonymous hemianopia, with macular sparing. Picture as seen in left homonymous hemianopia, with macular sparing. PCA occlusion. T1 MRI of PCA infarct. PCA, at level of branches to midbrain, Weber's syndrome. At level of midbrain, specifically the base. X. PCA, at level of branches to midbrain, Weber's syndrome. Manifestations, at level of midbrain. Motor weakness, contralateral hemiplegia, upper and lower extremity, corticospinal tract. Corticobulbar fibers in the cerebral peduncle. Ipsilateral lateral gaze weakness and diplopia, CN3 fibers, LMN. PI movements, patient is unable to move eye up, down, or medially in the ipsilateral side. Pupillary dilatation, if Edinger-Westphal nucleus are involved. Case. A 55-year-old African woman had abdominal surgery 2 weeks before suddenly remarking to her husband that she was seeing double. She also felt a weakness in her left arm and leg. Her husband noticed that her right eyelid was drooping. P.E. Her general physical condition was good. Eyes, right eyelid does not open fully. Right eye was deviated to the right, laterally. When asked to converge the eyes, only the left eye adducted showed pupillary constriction, right is dilated. Motor system, Motor strength was normal on the right but was reduced on the left, especially in the arm where there was an increased biceps reflex and resistance to passive stretch. Basilar artery occlusion, locked-in syndrome. Basilar artery occlusion, locked-in syndrome. Manifestation, at the level of the pons. Weakness of both upper and lower extremity, quadriplegia, bilateral cortical spinal tracts. Weakness of face, entire side, bilateral corticobulbar tracts. If lesion is big, horizontal gaze weakness, bilateral fascicles of C and V, only vertical gaze is possible. Dysarthria, bilateral corticobulbar tracts. Death from respiratory failure is common. Patent or alert, conspicuous with normal cognitive function. If very severe, the only way to communication may be blinking. Patient is locked in their bodies, quadriplegic, with dysarthria and facial weakness. MRI after 19 days in hospital. MRI after 19 days in hospital. Locked-in syndrome. A 62-year-old woman with a history of hypertension for 35 years developed left-sided hemiparesis. 1 week later she became tetraplegic and unable to speak. However, she was able to communicate by blinking. She died 3 months after the onset of her neurological symptoms. MRI after 19 days in hospital. MRI after 19 days in hospital. After autopsy. Locked-in syndrome. A quadriplegic patient with locked-in syndrome who managed to survive, less severe case. Labyrinthine artery syndrome. Labyrinthine or internal auditory artery usually takes its origin from ACA, but it can also take origin from pica or the basilar artery. It supplies the inner ear. Occlusion of this artery can lead to sudden tinnitus, vertigo or even unilateral ipsilateral deafness. Labyrinthine artery. Pica occlusion, lateral medullary syndrome of Wallenberg. At the level of dorsolateral part of medulla and cerebellum, pica occlusion, lateral medullary syndrome of Wallenberg. The commonest of brainstem strokes. Manifestation, at the level of dorsolateral medulla and cerebellum. Ipsilateral sensory loss of face, pain and temperature CN5 spinal N. Ipsilateral facial pain CN5 spinal N. Ipsilateral ataxia, arm and L restiform body, ipsilateral cerebellum. Ipsilateral gait ataxia restiform body, cerebellum. Ipsilateral nystagmus vestibular nucleus. Ipsilateral nausea, vomiting vestibular nucleus. Ipsilateral vertigo vestibular nucleus. Ipsilateral hoarseness nucleus ambiguous. Ipsilateral dysphagia nucleus ambiguous. Ipsilateral Horner syndrome descending sympathetics. Contralateral hemisensory loss, pain and temperature spinothalamic tract. Hiccups, whatever you do, it does not go. Prognosis is generally quite good with full or near full recovery expected at 6 months. Scan showing lesion in medulla and cerebellum in Wallenberg syndrome. Vertebral artery occlusion can also give Wallenberg's syndrome. Thalamic infarction, Dejeran-Rusi syndrome or central pain syndrome. PCA penetrating branches to thalamus. Very sad syndrome. Manifestation, pure sensory loss without weakness, due to lesion of contralateral Y, crossing below thalamus. Hemilateral sensory loss of all modalities. Hemilateral pain. Hypersensitivity, colon. If you touch their affected side, they will shout. PCA. MRI of the patient a day after. MRI of the patient a day after. After death, autopsy. Anterior spinal artery occlusion, anterior spinal artery syndrome. Complete sensory and motor loss below the level of occlusion except for proprioception, anterior spinal artery syndrome. Manifestations. Loss of motor function below level of damage, due to damage of corticospinal tracts, and post. Bilateral anesthesia, loss of sensation below the level of damage. Damage of spinothalamic. Loss of bladder and bowel control, damage of descending autonomic tracts. Proprioception is intact due to sparing of dorsal system. Motor and sensory function in face can be intact. Note: keep in mind that these are not the only syndromes we see in posterior circulation. There are many other syndromes that are seen in infarctions affecting other regions of brainstem, e.g. of other syndromes of midbane, Claude, Benedict, Knoth-Nagle, Raynaud syndromes. Pons, Millard-Gubler and Raymond Favell. Medulla, medial medullary syndrome. Quiz. Overall mortality for posterior circulation strokes is a 5% B, 20% circa 40% D, 70% E, 90%. One locked-in syndrome consists of A. Coma with quadriplegia. B. Bilateral upper extremity weakness greater than lower extremity weakness. C. Quadriplegia, bilateral facial and oropharyngeal palsy but preservation of cortical function and vertical gaze. D. Cranial nerve findings contralateral to motor and sensory findings.